Hi, this is Brian Kim. I want to share with you this case of a patient who was referred to me. This patient had cataract surgery 3 years ago and was told by the surgeon that everything went fine with the surgery, but the patient sensed that something wasn't right because she wasn't seeing very well out of the eye, and she kept coming back. Finally, she ended up seeing another doctor who then told the patient that the lens was dislocated. So that's when she ended up in my office. And she was really frustrated because she knew something was wrong with the eye, but she felt like she was getting a runaround. But I explained to her that, I'm sure the surgeon did the best they could, but unfortunately these things do happen. And so you're going to see this patient has a 3-year-old Tecnis Z9002 lens. And I'm going to, instead of taking it out and putting another lens in, I'm going to refixate this Z9002 lens, and it has these delicate PMMA haptics, which we know, most people do Yamane with the CT Lucia lens because the haptics are so strong. But that lens has had defective issues with the propellering of the haptic in the optic. I've been using the Sensor and the Tecnis lens for the last 2 years now, and I've been getting great results. So I'm confident we'll be able to refixate this Tecnis Z9002 lens. So you can see this is the patient's eye. You can see the lens is dislocated inferiorly and decentered as well. Honestly, it's hard to see any capsule remnants that are supporting this lens. I use the tip of a 27 gauge cannula with ink on the tip, and then I ink the limbus on the right side, finding 180 degrees on the other side using that cannula, the shaft of the cannula, and then marking the limbus on that side as well. Very important for symmetry and good centration. This is a fixed caliper. I'm going to indent radially 2.5 millimeters posterior to the limbus, posterior to that mark, and then 2 millimeters adjacent. And remember, you have to dry. This is so important. Dry. And you've noticed I did not make any incisions yet. Why? Because if you make an incision, the eye will be wet. So I like to make the marks before I make my incision while the eye is dry. So again, 2.5 millimeters posterior to the limbus, again in radial fashion, and then 2 millimeters adjacent with the fixed caliper. Again, the 27 gauge cannula has been inked. I'm going to just dab it on the scleral indentation area and do the same thing on the other side. Again, using the Wexel sponge, which is very important. And you want to have the eye in the neutral position. And the eye being in the neutral position means that the mark that I made will reflect my intended scleral needle placement. I switched to a cotton tip. A cotton tip is much better at manipulating the eye than a Wexel sponge. And then I make my incision for externalizing the leading haptic. It's going to be contralateral to my main incision. And then I'm making my incisions for the removal of the lens for the explantation, first on the right side and then the left side. And because I'm going to refixate this lens, I'm not going to make a big incision for my main incision. And I'm going to make this incision, maybe a couple of millimeters. And then I'm going to inject some dispersive viscoelastic to coat the corneal endothelium. And then this is a 25 gauge needle. I'm going to bend it pretty close to the tip. Again, the bevel is going to face to the right. And now I'm going to use microforceps, and these are smooth microforceps. I'm going to gently turn the lens up into the anterior chamber, and I'm going to try to get to that leading haptic. And you'll see what I'm going to do. I'm going to try to passively externalize the leading haptic, do that contralateral limbal incision using that passive docking technique. I'm going to dock the haptic on the bevel of the 25 gauge needle and slide it out. So again, typically I will use the injector and put a new lens in and do it all in one maneuver. But in this case, I'm trying to refixate the Z9002 lens. So go ahead and place the 25 gauge needle through that contralateral limbal incision. And very carefully, I'm trying to find the leading haptic. And very carefully, again, remember, the haptic is very delicate. And so rather than trying to bend the haptic, which is bad technique, I'm rotating the needle towards the haptic, right? So obviously it's a little awkward, and so sorry that my thumb is in the way here, but I'm turning the needle towards the haptic and I'm gently trying to feed it. Now, the problem is the needle needs to bend a little bit more, and I'm not able to get a good angle. But you see here, I went ahead and just pronated my hand, and as I pronated my hand, I'm able to approach that haptic a little bit better. You see that? So by pronating my hand, I have a better approach. The needle is facing the haptic a little bit better, more aligned. And now look, you can see that I'm able to thread the haptic into the needle rather easily here. I probably put in a little bit more haptic than I needed to, but that's fine. And I pull out the needle and then the haptic is out. So I'm in great shape. Again, I did not crimp or grab the end, the tip of the haptic. Therefore, I'm able to then scleral fixate and then use that 30 gauge thin wall needle with the haptic and cannulate the haptic into that 30 gauge thin wall needle without worrying that it won't cannulate through. So I reposition the trailing haptic in such a way that I'm able to get to it. And now here I'm bending my needles, first the right needle and then the left needle. And I'm sorry, it was off screen. You've seen me do it many times on my previous videos. So again, I filled the eye with viscoelastic. Remember, I haven't vitrectomized a patient, but I make sure the globe is nice and firm, and I'm holding the eye in the neutral position. I stabbed the conj and the sclera. You saw that there was no movement of the conj. I tunneled 2 millimeters, and then I dove down. And so I have perfect scleral shelf because I tunneled 2 millimeters. And now very carefully, irrigating the eye, I'm going to push the optic away from me, try to tilt the forceps down because the haptic is a little bit under me here. And remember, I didn't pull the haptic out, and it's because I knew that I could grab it. So now I have the haptic, the trailing haptic, and I'm going to fixate that right side needle. And here it's all about aligning the haptic to the needle. Remember, the haptic is curved, the needle is straight. And so you have to adjust the haptic to the needle. And you will notice that the bevel is facing towards me, but honestly, I had the needle bent towards me, but also facing upward towards the microscope a little bit. And so because of that angle, I normally don't do it that way, but I was changing my angle just a little bit just to see if it would work. And even though it did work, normally I have the bevel typically facing the actual incision and not facing the microscope. Nonetheless, I was able to feed it just fine. I disengaged the needle from the syringe with a hemostat, and then I'm carefully internalizing the leading haptic into the anterior chamber. Again, the eye is filled with viscoelastic, nice and firm. I'm holding the eye in the neutral position. I'm stabbing the conj and sclera. Again, it hasn't moved. It's in a neutral position. I'm going to tunnel through the sclera 2 millimeters. You saw I was able to puncture, and then I flattened it out. I don't know if you saw that nuanced maneuver. I stabbed, flattened out, I tunneled 2 millimeters, and then I dived down. Again, doing it this way, I made sure I got a nice scleral tunnel, which will ensure a nice scleral shelf, and the marks didn't move at all during the scleral fixation component of this technique. And now I'm going to very gently grasp the leading haptic using smooth forceps here, flatten the haptic on the bevel of the needle, and it goes right in. So again, I didn't really have much trouble with that one. Again, by doing the trailing haptic first, it makes the leading haptic much more easy. And truth is, the trailing haptic is really the hardest one. I pulled the left side needle out, making sure I have the forceps ready to go, and then I cauterize the tip. Again, with this lens, in contrast to CT Lucia, the CT Lucia haptics do tend to slip out of the needle as you try to externalize the needle. And it does also tend to slide into the sclera. These haptics don't do that. These PMA haptics of the Tecnis and the Sensor don't do that. So now I've cauterized the left side. I'm pulling the needle out on the right side. This is when I realized I did internalize a lot of haptic on that right side. And again, you don't have to do that with these haptics because they do grip the needle lumen much better. So I go ahead and cauterize the tip. You can see the flat profile of the haptics, and they're fairly symmetrical and parallel to the limbus. Very important in order to be able to get a good anatomical result. So again, you can see nice and flat planar appearance of the optic, and it's well centered. And again, that's because why? It's a flat to the sclera and symmetrical, right? So they're both parallel to the limbus as well. So I speed up this section because I'm just putting in a tendon-on suture. I always close my main incision with these cases because you never know. I don't want vitreous at the end of the case. And here I am going to go ahead and do some vitrectomy because you can see some capsule remnants and there's no reason for all that. But interestingly enough, I encountered no vitreous throughout the entire procedure. Okay. So again, dislocation of a lens in this context, in my experience, is usually because of vitreous liquefaction. And so again, this patient didn't have any vitreous in the anterior chamber. During the refixation, I used the AC maintainer, limbal AC maintainer to do the vitrectomy. Again, no vitreous whatsoever throughout the entire procedure. I switch sides with the irrigation and the vitrector so I can get a better angle to remove any potential vitreous now on the right side. And then now I switch to the surgical PI setting, and I turn the port down. I want to eat a small bit of iris in the angle temporally, but not all the way to the periphery. Otherwise, you might hit the ciliary body and cause some bleeding. And then once I do that, do some more vitrectomy. Really, essentially, I'm just trying to remove any of the viscoelastic in the anterior chamber. And here I'm using a BSS cannula to just pulse into the anterior chamber, loosen up some of that dispersive viscoelastic. And here I'm just pushing BSS to loosen up any viscoelastic that's stuck in the anterior chamber. And then I hydrate my incisions, and that's essentially the end of the case. So again, this is a patient who had a dislocated Z9002 lens put in 3 years ago, sensed that something wasn't right with the surgery, didn't have good vision in this eye. The other eye did fine, but this eye, she could tell the vision was not that good. And she, again, asked the surgeon, was everything okay? And the surgeon said everything was fine. Ended up seeing a different doctor who then told the patient that the lens was slightly decentered. And so that's when she started to realize something wasn't quite right, found me as a third opinion, and went ahead and took this lens that was, again, tenuously in the bag. I'm not quite sure when you look at the lens if it was in a sulcus. I didn't really see an anterior capsule rim. You saw a lot of capsule remnants that were there. In any case, I was able to refixate the Z9002 silicone Tecnis lens, again, by externalizing the leading haptic through a contralateral limbal incision with a 25 gauge needle docking technique using microforceps, again, smooth forceps. By doing it that way, I'm able to secure the lens, push the optic away from me. Therefore, I was able to fixate the trailing haptic with the right side needle in my typical technique. Again, docking the haptic on the bevel of the needle, sliding it in, and then doing the same thing on the left side as well. And again, because these haptics tend to hold on to the 30 gauge thin wall needle, very low risk of the haptic slipping out when you're trying to externalize it. So whenever you encounter a lens that can be refixated with the Yamane technique, if you had a dislocated CT Lucia, Sensar lens, a Tecnis acrylic, a Tecnis silicone, any of those lenses, you could theoretically refixate the lens, but you have to have the proper technique in order to be able to do that. And the technique has to be gentle on the haptics. That is really the key with this technique. And because of the way I do this surgery all the time, and because my techniques are gentle on the haptics, I felt very confident that we could refixate this lens, and this patient did very well. So I hope this was helpful to you, and I thank you for your attention.